Lisa Juckes. I had the pleasure of working alongside Lisa in Dubbo many years ago and learnt a lot from her. She holds specialist qualifications in general adult and addiction psychiatry. She's interested in helping people of all backgrounds from youth to old age with mental health and substance use needs. She's committed to helping people flourish, restoring their autonomy and encouraging growth and improved overall well-being. Dr. Juckes has worked in the public sector, NGO and private mental health and AOD settings in metropolitan as well as regional centres, and has been involved for many years in advocacy and academia. Welcome.
Thanks everybody. Where's Kelly? Oh, sorry, right in front of me. Kelly, that's going to be very hard to follow you. Thank you so much. Thank you for your courage and your tenacity, and I'm really glad you found your tribe. As a psychiatrist, I'm going to just quickly take this opportunity to apologise for the terrible experiences that you had in the name of psychiatry and mental health, because clearly very unhealthy, very toxic, and I really do hope that not all psychiatrists and psychiatry training has the same outcomes, and so much to do. Okay, great. Thanks also for your coffee tip this morning. Okay. Right. Gosh, you navigated this, and is it the green button? Thank you. Oh, the top. The big green button, not the little one. Thanks. Okay. So I guess some of the themes that I'm going to speak about today echo some of what you've really clearly described, I think. And so you'll hear this theme a lot about people that we're seeing, whether working in mental health or AOD services or where I'm currently working. I'll tell you about it a little bit in a moment. That people are not recognising and coming in and saying, do something about my substance use, it's a problem. My substance use is actually maybe what's keeping me alive, what's helped me get to this point. It's how I'm coping. It's how I'm getting through my day and so on. So I really want to acknowledge that up front. Firstly, I would also like to acknowledge the traditional owners of the lands that we're meeting on, both here, Gadigal country, but also I understand there's quite a lot of people who are online, all the lands that you are living and working on as well. I'd like to pay my respects and to honour elders past and present, and extend my gratitude as well for the continued wisdom that they weave through all facets of our life, spiritual, physical, emotional. I'd also like to recognise people with lived and living experience of mental health and drug and alcohol and other addiction issues, some of those who may be here today. Okay. Oh, so I've got this slide. I'll leave that in the background. I think we're all pretty familiar with what comorbidity means, certainly in our day-to-day work, but I guess I just wanted to say that this term is used a little bit differently, and in some areas, I think we need to remember that comorbidity also extends to other physical health issues, particularly chronic pain, other medical conditions, intellectual and learning difficulties, and other disabilities. So when we talk about comorbidity today, I think we're particularly talking about a range of mental health as well as drug and alcohol and addiction issues. Okay. So I've got the grey hairs to testify. I've been a psychiatrist for quite a few years and I have worked in a number of different areas. And as Michelle kindly introduced me, I am actually an addiction psychiatrist, which is a fairly controversial term, I think, because I think actually having an understanding of the issues of addiction, drug and alcohol issues is actually core business for psychiatrists. And yet even our illustrious college recognise it as a subspecialty, so a separate faculty to recognise addiction psychiatry. I've always kind of advocated, though, that being kind of bread and butter work. But interestingly, I think that's reflected in our thoughts about mental health. Has anyone got a DSM in their briefcase? Right. There's a really big section, even in the DSM, just for addictive kind of conditions, whether substance or other process addictions. So it's actually a big part of mental health. But we are still, many, many years on, talking about as if they are separate things in separate sectors, separate silos. So for me, training as an addiction psychiatrist, really, I think that's just being a psychiatrist. I'd also just like to, I do have a couple of hats, but my hat today is my youth mental health service hat at Uniting Recovery. And thanks for those people who are here from Uniting as well today. So I guess what I'm also going to whiz through some of these slides because I think we know about this, the prevalence and the major issues of comorbidity, of drug and alcohol use and other addictions, and our mental health clientele that are coming to our services. But really what I want to kind of talk about, because I'm a bit more excited about that, is how we've tried to tackle some of this issue on the ground in our clinical service, which is in the Northern Sydney PHN. And we work in the YES service, which is for moderate to severe mental health presentations of young people, 12 to 25, and their families. So we do individual and family therapy. We see people for up to a year, which often isn't long enough, but it's longer than what people get in a lot of the sort of public kind of settings. And traditionally, I've been there for almost a year and a half. Traditionally, we had eligibility criteria that were really clear to make sure that we steered people with significant drug and alcohol issues to other services, like SDEC, Belinda. Okay, so I'm going to just I think if you're comfortable with me whizzing past these, I'm going to do that. We can always come back if I've sort of shortchanged anybody about the issues and the significant harms that we know about and that we see and that we're trying to help people with every day. Okay, so I just want to kind of highlight that I think this is particularly important. I'm passionate about working with young people because this is a fabulous opportunity to intervene early. And if you intervene early, we also know that briefer interventions are often more effective, so we don't have to work as hard, right? That's got to be a good thing. But it has potentially a massive impact for helping people with the trajectory of the rest of their lives and generations to come. So I think really important working with young people, intervening early both for any substance use and mental health conditions, but also their family with whom they're usually embedded or their other kind of substitute family network. Okay. I'm just going to go past these. Okay, so we know that comorbidity is common and we know that it is costly. And you can see the point at the bottom here, right? People who, if you're working in an adult service, people that you're seeing that have got significant mental health and or AOD issues, most of them develop those before the age of 25. Okay. So what are the recommendations? Well, we've been hearing I've actually been a psychiatrist for more than 15 years, and it's more than 15 years we've been talking about having integrated services. I did my final year training. I had a special training fellowship through the Institute of Psychiatry, and that was a particular area I was looking at for behavioural therapy for people with schizophrenia and substance use disorder, so it goes back a really long way. We are still recommending integrated care. And it's interesting, I've become aware that integrated care means different things for different people. So what I want to talk to you about today, so we know that that's preferable, lots of research that's been available for some time, but pretty challenging to do. Okay. So why is it though so challenging? Why do we have these recommendations for decades and yet we're not actually able to work in that way? And I worked in public and I've worked in private, I've worked for NGOs, different age groups. I worked in the city, I've worked out in regional towns. Any thoughts? Why don't we actually follow those recommendations? We do like evidence-based care, we struggle following it, don't we? Well, I'm going to talk about, I've worked in AOD services where our funding came to provide AOD interventions. So, yeah, we see people, they come along, they often mostly self-referred, except the other place I worked that wasn't self-referred or voluntary was the involuntary drug and alcohol treatment program. That's another whole way of looking at things and talking about things, which I won't do today. So people with drug and alcohol problems or somebody in their family might bring them along, turn up at our AOD services. It usually needs to be voluntary, you need to be self-referred and so on. And, and you have to be kind of self-motivated, really. Big problem if you have a significant addiction, I might add. Part of the way our brain's affected in the course of active addiction is it affects motivation and decision-making and choice. You could even say it's a disease of choice because it's really hard to make good choices. Okay, so Having worked with a number of different drug and alcohol agencies, in fact, some of my role in the past has been to provide some of the mental health psychiatric perspective in those AOD services. So we know that people with AOD issues have a lot of other comorbid mental health problems. Sometimes if they're too severe, they might get turned away from their AOD service. Okay, so there's a rationale for increasing training for AOD workers to have some mental health background. Is Christina here? No, I saw you there, Kath. Okay, so fabulous guidelines, really, really helpful. Belinda probably recognises that. Okay, and some work I do is sort of Far West with an Indigenous organisation. Again, I kind of wear a dual hat in that, but it's a drug and alcohol service. Okay, now from a youth mental health perspective, where we're working in the YES service in Northern Sydney, so we see people with mental health problems coming to mental health services. Good, so we're getting out there and we're actually open for business for some of our from our core cohort. Well, we also see that people coming to those services, they've got drug and alcohol problems, they've got gambling problems, internet overuse and so on. So we actually do have people with AOD issues turning up to our service. Now, to get past intake until about a year ago, you maybe didn't lead with that, and you maybe didn't have your referrer write that as the primary presenting problem, because that would not have met our eligibility criteria. Now, people who've got comorbidity, mental health and AOD addiction issues, they also present to our services, and I would suggest in the young age group that they're more likely to turn up to a youth mental health service, as I was saying before, because the substance use is not the problem. The substance use is the coping strategy that they might reluctantly tell you about later on because they're already aware that you might try to get them to stop doing that, stop using those things. Okay. So if you do present to a drug and alcohol service, you've often got to the point where you or somebody really close to you has put their foot down and recognised that this is a really, really significant problem. So that's not to say that people coming into the youth mental health service don't have significant AOD problems by the time they present, but it's the mental health complications, if you like, or the mental health difficulties that are leading them to seek care, or their family to seek care for them. Okay. So working in mental health at our service, there has been a bit of a, well, don't ask. You don't open the Pandora's box, I think somebody referred to it as. And I think for a lot of our clients, it's also don't tell. People have had really negative experiences disclosing their substance use disorder when they're trying to seek help for their mental health problems. Okay. If you look back at the kind of assessment forms that we were using for initial assessments with people being referred in, well, there wasn't actually many questions anyway about AOD use or gambling or gaming or anything like that. If they were used, the boxes often weren't ticked, so just left blank. Not routinely asked as part of our standard assessment. And sometimes deliberately avoided. Why did you not fill that bit in? Well, a lot of the clinicians actually kind of said they didn't feel that they were comfortable asking those questions. You can't ask those questions when you first meet people. That'll be. You can ask them about all sorts of other personal things, but you can't ask them about their coping strategies and substance use. Okay. And as I said, the client goal when they come in is often not actually around addressing the substance use. Okay. So somebody says, I'm not trained as an AOD worker, I don't know what to do if they disclose. I'd rather not hear about it. Anyway, we're not funded because that's not our job. Okay, we'll send them to the AOD service, that's their job. They can come here for the other psychotherapy that we're doing, but they have to go somewhere else, and we'll make some phone calls. Okay. And I don't know about you, but I find it hard enough just to get to the dentist and do some basic kind of things like that. If somebody says you've also got to go somewhere else, you've got to come see me every week for your psychotherapy and your family sessions, but no, go somewhere else for your AOD use. Probably not going to happen, is it? Okay, so we just thought we'd do a quick sort of survey across our clinicians in our service and just say, well, look, what's your baseline kind of sort of comfort level and knowledge? Paul, you might just want to, look the other way. Okay, so I just cherry-picked a few things here because they sort of stood out for me. So 65% of our team said that they didn't actually feel comfortable to conduct an initial sort of assessment, which is kind of just talking with somebody about what they're doing, right? Yikes, that was scary. So none of the respondents across our team said they'd ever received previous training in the recognition of things like tolerance to substances. Most of them wouldn't recognise nicotine withdrawal. And only a third of them, and that was the best, right? Only a third of them said that they would be somewhat comfortable of doing an assessment of non-substance or process behaviours. Okay. Oh, and 75% didn't actually feel comfortable giving any kind of harm reduction advice to 12 to 25-year-olds. Okay. So how to respond? I took my own pulse first, right? Breathing, I feel a bit calmer. Well, okay, what are we going to do? Okay. So possible responses we kind of thought about, well, you know what, let's just look the other way. We'll just keep on intake, make sure people on intake, and when we discuss it at meetings, what about this person? We're going to see this person, his family. No, that's too much drug and alcohol for us. We're going to send them to Belinda at SDEC and her team, or we're going to send them somewhere else. So we'll just keep saying you can't come here, all right? Too bad about your school refusal and your anxiety and your depression and all those other things. They'll fix that there anyway. Yeah, we could keep referring out, decline service, and so on. Or we could train all of our clinicians with the manual to have better assessment skills and build up their confidence. Not a bad idea, but that actually takes quite a bit of time. What do you do with the cohort of people that you're already seeing? I'm only there a few hours a week. So then we kind of thought, well, what if we could recruit a senior alcohol and other drug clinician, ideally somebody who's had their own lived experience and is in recovery, and have them join the multidisciplinary team. So our multidisciplinary team is made up of a little bit of psychiatry time. We have sort of early career social workers, psychologists, mental health nurse, and we have a peer support coach. So this would be a really big addition to our team. Okay. Some of the benefits, seems obvious to me, I thought it'd be a really good idea. But we thought, we could upskill the clinicians by working alongside rather than sending them off to training courses or, having them sit down with the manual and have a test or something afterwards. And that they would be able to have input on case reviews as well as seeing individual clients and families. And that way they'd have access to much greater experience and expertise rather than sending everybody off to train them up from scratch. So the way our service works, given the frequency that we're working with people, the caseload for the primary mental health clinicians is about 20 clients seen for up to 12 months. So if we have just one more full-time clinician, that's maybe 20 clients and families. That's not really that many. So we actually wanted to have a model where they were not the primary health clinician, but actually would work alongside all of the primary health clinicians in our service, mental health clinicians, I should say. Okay, so we're sort of in that sort of pilot phase. Hopefully I can talk to you again in the not too distant future with some proper numbers. But just to give you a little bit of an overview, in that first few months, even getting them sort of settled in and so on and getting the team used to having, we actually got 2 people who are doing a job share. And so of about 38 individuals and families, the diagram there, it's probably hard to see at the back, but the dark blue is identifying people's own alcohol and or other drug use. And the orange wedge is where the intervention, if you like, was, excuse me, where it's somebody else in the family. Okay. So you can't read that probably in the slides there, but principal drugs of concern, the far left is alcohol, nicotine, cannabis, cocaine and methamphetamine. And secondary drugs of concern, alcohol, cannabis, ecstasy, nicotine, methamphetamine, and a little one for benzodiazepines down here. Now, there were other drugs because a lot of young people were using a lot of drugs. I haven't had the sophisticated enough approach to put all of that in, so that will be coming. Okay. So, I'm not sure how much time I've got here, but there's a couple of, about 5 minutes. It goes really quickly when you're up here, doesn't it? Okay, so look, I won't go into each of these cases in great detail because I could talk about each of them for hours. I just popped these up here just to give you a couple of examples. And each of these would have been people or families where we would have said in the past, oh, now we've discovered this is too hard. You know, we've got a few months into working with you, but you're going to have to go and see somebody else. Or you'll have to see somebody else as well, and we haven't actually had to do that. So a 16-year-old who's referred, the referral actually states it's for her chronic low mood and distress. There's lots of dissociation, this sense of inner emptiness. There's a lot of self-harming by cutting and hitting her head. And she's engaging in things like pretty out there kind of phone sex, soliciting strange men to have sex with her from different countries. One of them who found her address and was stalking her. And she's using alcohol and cannabis and sniffing deodorant for the effect of the butane. So she'd had a diagnosis of complex PTSD and dysthymia. I think that really didn't explain things very well. But she also had some disordered eating where she would go through phases of punishing herself by starving herself and then other times eating so much she'd be sick. And kind of described that sobriety was unsatisfying. So in talking to this young woman with what's going on for her, you know, it turned out that she was, as well as the cannabis and the deodorant, really what she was spending most of her time. This is a medal-winning high school student, I might add. But she had been either stealing hand sanitizer. She stole hand sanitizer first from the school library and found that that was a pretty good way of getting a high alcohol concentration. So then she would get large quantities of hand sanitizer and she would use lots of salt to sort of distill the alcohol out of it. It was pretty technical. I didn't know how to do all of that. And she'd also set up a little alcohol still in her bedroom so that she could distill her own alcohol. This was by the age of 15. So she'd had some admissions to hospital, very brief admissions, in and out through the emergency department after massive paracetamol overdoses and an alcohol intoxication where she was comatose from her homemade alcohol. No other interventions, by the way, just when you're well enough to go home medically, we'll discharge you. So another young woman here, the referral said, could you see this person to help manage her stress and anxiety and low self-esteem? There was a prior diagnosis of bipolar disorder and PTSD. This person she had a lot of developmental trauma, amazing kind of resilience, survivor that had got her through the last several years of her life. A little bit like what you were saying, Kelly, you can see there, she'd been medicated with some fairly interesting combination, fairly decent doses of medication, and these are her mental health symptoms. So this was meant to bounce in, so you didn't see those before, but a lot of mental health symptoms that she's describing. And so the AOD history from the referrer, there was nothing. That was one of the ones with not even the box ticked, when the box is there to tick the box like yes or no. The mental health clinician with the initial pass at intake said, you know, about, do you use any substances? Oh, I use a bit of cannabis to smoke. I smoke a bit of cannabis to cope with all these mental health difficulties I've got. And you know where I'm going with this, don't you? A fairly extensive drug and alcohol history for this young person. Okay. So here's another one where they're using lots of a fair bit of cannabis. They're vaping. They've also got the first person in our service who's been getting the Zins imported from overseas. So they're little oral nicotine pouches. I wanted to talk about all the fabulous things that I don't have time. Anyway, I'll sum it up as saying it's actually been really gratifying seeing that as a team we can now work with these people and these families and keep them in our service for that episode of care. This last one, I'm sorry, the writing's really small, but it was just kind of to illustrate a family where there was a lot going on for the identified client, who was a 13-year-old with ADHD, Tourette's, trichotillomania, lots of anxiety, threatening suicide several times a week. There was some behavioural issues at school, difficulty with peers, and had been told, no surprise, you couldn't get mental health treatment elsewhere, and they'd gone to a lot of places over several years. You're too complex. Seeing the whole family with with a mental health clinician. Really, this was going to be a family intervention, and it became apparent fairly soon that Dad is actually really depressed, completely defeated, part of this daily conflict cycle, and he's coping by dependent drinking. Okay. So I just want to say there have been some benefits to date. So obviously, as I mentioned before, we're actually keeping people in our service, so our eligibility criteria is much broader now. We're not having to exclude people. In fact, I checked in with the team just yesterday and they said, I don't think we've actually referred a single person out because of their drug and alcohol use since we've had the clinicians on our team. So that's pretty impressive, I think. But I'm pretty sure SDEC and other services are still getting plenty of business, so I don't think we're, upsetting anyone there. And from the clinician experiences, they're increasing their knowledge, they've got increased confidence, they're learning with these really impressive mentors alongside. They've actually said they're much more likely now to ask about drug and alcohol use. In fact, they're quite excited about kind of asking people and having a discussion with them about why what do you get from your use, what's that like for you, and so on. And then they've got help applying that knowledge. The other unexpected benefit is that 2 of our team members have also decided that they wanted to quit nicotine and have had some support to do that. Okay, so I guess take-home points, really obviously just want to say what we all know, comorbidity is still really common and it is still really costly. People present with what they think are the problems that they're seeking help for. As clinicians, we often have a broader understanding and we need to kind of bring that to them, not expect them to go to different places. We do need integrated services, and I think integration, and with all respect, I think having things under one roof can be helpful, but you know what, if it's under one roof but you still have to make a different appointment on a different day to see somebody this end of the corridor to that end of the corridor, that's still kind of a parallel treatment. I really want to advocate for a model that we've been really enjoying trying out, where you've got the clinician embedded in your team and you're seeing people together. Thank you.